Okay, good afternoon, everyone, and welcome to the Canadian Emergency Trauma and Acute Care Radiology Society webinar. I would like to begin by acknowledging the Indigenous people of all the lands that we are on today. While we meet today on a virtual platform, I would like to take a moment to acknowledge the importance of the land, which we call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations, to improving our understanding to local Indigenous people and their cultures. From coast to coast to coast, we acknowledge the ancestral and unceded territories of all the Inuits, Métis, and First Nation people that call this land home. My name is Adnan Sheikh. I'm a ER trauma and musculoskeletal radiologist and clinical at Vancouver General Hospital, and I'm a clinical professor at the University of British Columbia. As the president of the CETARS Society, I'm delighted to moderate this session on behalf of the Canadian Association of Radiologists. Before we start, a special thanks to our sponsors today, Bayers, for their unrestricted educational grant for our webinar series. This webinar is accredited group learning activity of the MOC of the Royal College of Physicians and Surgeons of Canada and is approved by the Canadian Association of Radiologists. Participants are eligible to claim a maximum of 1 hour. A certificate of attendance will be emailed to the attendees after the webinar. Before we begin, a few housekeeping comments that all the questions will be saved to the end of the session. Please use the chat feature to enter your questions. The webinar will be recorded and will be available on the CAR website. Today, we will be learning about the imaging of suspected child abuse and imaging of elderly abuse. We are very fortunate to have two renowned speakers, Dr. Samuel Staffres, a pediatric radiologist and associate professor in the Department of Medical Imaging at McMaster University, and also Dr. Volker Berger, a radiologist and associate professor in the Joint Department of Medical Imaging at the University of Toronto. Dr. Staffres will be speaking first, and the title of his presentation is Overview of Imaging of Suspected Child Abuse, and that will be followed by Dr. Berger, who will be presenting on imaging of elderly abuse. Samuel, over to you.
Thanks. Thanks for the invitation, and thank you to the organizers for putting all this together. I'll share my screen. I'm assuming we can see. Okay, so my name is Sam Staffres. As Adnan has kindly said, I'm based at McMaster Children's Hospital in Hamilton. I've been there for a couple of years. My main areas of interest are musculoskeletal and mostly abdominal pediatric radiology. I'm going to try to cover a lot over 20 minutes, so I'll keep it succinct and I'll give you a few references where you can go and learn a little bit more about the topic. Which is really something which anybody who works with pediatric imaging comes across quite regularly in their practice. So we need to be quite well versed. Conflicts of interest, nothing in particular from my end, apart from saying that I'm a member of a few societies and I am speaking in my own capacity here, not in the capacity of the societies themselves. The learning objectives are quite short. I really would like to raise awareness of the condition, make us think about it more, in our reporting piles. I will direct you to a few of the imaging guidelines, pathways, algorithms, depending which part of the world you come through, what they are called, and show you kind of a few good references where to get them and what's going on in the outside world. There's a lot of work happening at the moment on imaging on suspected child abuse, with a lot of very good papers coming out in the next 12 months, answering a few questions. And also we'll look at a little bit of radiological findings, of course, that make us think of the condition. Unfortunately, there are multiple forms of child abuse, and they are much more common than what we actually think. You're just looking at some literature from about 13 years ago from the UK, where an estimate of 1 in 14 children suffered some form of physical abuse, which is quite a staggering figure, in my opinion. This is just talking about physical abuse, not the other forms of abuse, which we may be all aware of. Realistically, many radiologists don't get much training around this. I didn't get much training in my residency program, and you kind of start to see it more when you move into pediatric radiology. So there is a bit of a gap there in the training related to this topic. But if you do work in pediatric imaging, then one really needs to be comfortable with recognizing important findings about this topic. Confusion about terminology also exists, and just to show you how old I am, this is kind of how the terminology moved across the course of my career. The term shaken baby syndrome we still come across it, but it's mostly related to neurological injury from physical abuse. And the big term, which still comes quite along, is non-accidental injury, NAI, although suspected physical abuse has become much more common term to use. On this side of the pond, inflicted injury and child maltreatment is more the terminology which I come across on a regular basis. They kind of all allude to physical abuse in children, but have some slight different connotations to them. And if you want to read a bit more around that, a couple of good papers there on the side. Sorry about that. So as a radiologist, we really need to be aware of the condition. And if we suspect or it crosses our mind, look into the notes and communicate with our referring physicians that we have suspicion about possible abuse. We need to get comfortable with the variants and the differentials of the condition, and be comfortable also for the next question of what should we do next. So with the imaging algorithms, and know also our own limitations, which is sometimes the difficult bit. And if we're not sure, we need to ask for help from a colleague or from somebody outside the institution, if and when required. So when should we think about it? It's mostly when there is injury in non-ambulatory or children that are totally dependent. When the mechanism isn't really consistent with the injury, and that comes with experience as well, but we need to think, does this make sense? If this is what's described and we see a particular injury, we need to correlate them between each other. Household falls rarely actually result in fractures. So these kind of things where we think, does the story make sense? Similarly, with evident delay in seeking attention from the carers, and this sometimes comes to us because we may look at a fracture and think, this looks like it's healing, but then the notes say the injury was a day or two ago. So radiologists often pick on these subtleties that perhaps may not be in the expertise of the primary physician who's looking at the radiograph kind of acutely, and we're reporting it behind the scenes. Again, if there are multiple fractures in the context of a healthy skeleton or a healthy child, and there are obviously injuries that are associated quite highly with abuse, which may be on the notes or on the referring form, that would make us even more alert to looking for findings of abuse on the radiography. And how do we come across it? It can be just sitting there in our reporting pile. Often the next day, the child may already be discharged if we're reporting EDs, for example, the next morning. Remember that sometimes we are the only ones that will have access to prior imaging. Perhaps this is a patient that has presented with other images, other fractures in the past somewhere else, and we may be able to access it through the PAC system, which may not have been available to the frontline physician seeing the child and referring them for the radiology. So the evidence has shown us that there is quite a number of specific fracture patterns that seem to be have a higher association with physical abuse, and in particular rib fractures. And I'll talk about rib fractures in a minute, a bit more specifically. Children rarely fracture their ribs, even in the context of significant trauma. We rarely see rib fractures, and there has to be a significant force. But on the contrary, there's quite high association with posterior fractures in child maltreatment. So they are significant findings we should not underestimate. Similarly, particular type of metaphyseal fractures, the so-called corner fractures, which again I'll touch base in a minute, on are very highly associated. And then there are a number of rare fractures, which we don't often see, but that when we see them should make us think about physical abuse. So the scapula, the sternum, and also the spinous processes. As we go down this way, the specificity of the type of fractures and their relationship with abuse decreases, for example, but complex skull fractures and fractures of the digits of the fingers in very young children under the age of 2 are not normal and really should make us think, so the patterns, but the highest specificity with child maltreatment are this list on the side here. So with ribs, as I said, I mean, often what tends to happen with these children, we if there is a suspected abuse, is a young infant with unexplained bruising, they get a skeletal survey, and I'll give you an algorithm in a minute. And we really need to look closely at all the x-rays that depict the ribs. And in this case, for example, there was one single rib fracture, which you can identify quite nicely, even on the spinal radiographs. And sometimes what we find is we bring up all the images we have and put them, next to each other in different angles. And what I've learned is that very often in the oblique rib views, which are part of the skeletal survey, we should try to train our techs not to omit the contralateral side, to crop the image before sending them across to PACS, because every view is helpful when we are in doubt with these kind of things. And although we are here looking at the right ribs in an oblique projection in the second image, it would be important not to crop the left side as well. Here's another case, a young infant again sent to us for a second opinion in this case. And this is what is more common, that when you find one fracture, you tend to find many more. And this is one of those where we've got multiple rib fractures of different ages, fracture of the humerus, fracture of the scapula, again, red flags. I think that clavicle is also gone there. So the reality is what experience teaches us: when you find rib fractures, very often, the more you look, the more you see. So the previous case was quite uncommon. And from my experience, I haven't come across one with one single rib fracture in the past, but I guess it is possible, right? So the ribs are very important and we need to look for them. The other highly prevalent fracture with child abuse is the so-called classic metaphyseal lesion, also known as corner fracture, also known as bucket handle fracture. We're referring to the same type of injury, which very often, I'm just going to zoom in this first image here, very often comes across as an irregularity of the metaphysis. You often have a lucency crossing over, and you get a bit of like what looks like an avulsion, small avulsion fracture fragment in the periphery of the metaphysis in this young infant. In this case, we already can appreciate some periosteal reaction. These kind of fractures are very highly associated with non-accidental injury, but they are quite difficult, and they are difficult for a number of reasons. They can be subtle. It depends very much whether the periosteal reaction is there or not, depending on how proximal the fracture line goes and whether it does actually tear off some periosteum, because you may not have a periosteal reaction with these. They heal quite quickly over the course of 3-4 weeks, and they may heal with periosteal reaction or not. This is a very interesting case, in my opinion, because this is the same child. I've put the index imaging on the right and the index imaging on the left. As you can see, the right side is quite convincing from the index imaging, but if you look at this follow-up skeletal survey at 14 days, it's a bit more challenging to see. On the contrary, on the left side, with hindsight, yes, there is a fracture probably at the edges here, but much more convincing in 14 days' time. And I find that often it's not just related to the stage of healing, but actually the angle of the projection, how you catch the metaphysis, that makes a difference in how easy or how difficult it is to identify these kind of fractures. And to add insult to injury, you then have these variants, which are very common in the metaphysis, things like the color here we've seen the distal radius, and this kind of beaking, which I'm showing you an example in the distal ulna. These are things which we see in different bones. The beaking we frequently see in the distal femur, frequently see in the phalanxes. And one needs to get very comfortable with the variants to be confident to call classic metaphyseal lesions or corner fractures. So the question, of course, comes down to who should be imaged and how. Realistically, in a preambulant, in a child that isn't walking, any fracture is quite suspicious, and one really needs to correlate with the history, as I said before. Very often, at least in every algorithm you look at, depending on which literature you follow, there is a very detailed examination of the skeletal system, trying to look for other fractures or history of other fractures. And depending on the age, neuroimaging. And these protocols very much change if it's an under one, between 1 and 2, and over 2 years of age. This is a interprofessional assessment. We do play a very important part as radiologists, but there are many other findings which are clinical and the history, and this goes to the child protection team or child advocacy team, and they are the ones normally to refer to us for these kind of further imaging based on their assessment at the time. So if there are more risk factors, we're more likely to be imaging the children. It's important to get double reading, and every protocol really mentions that in this situation, both because the stakes are high and the images can be difficult to interpret, but also because these end up very often to be medical legal cases. It's important to have 2 independent radiologists look at the imaging and then compare and come up with one common report. And a couple of things, it's important also to forget the babygram. If this is with a babygram, I mean the classic X-ray where you have one X-ray trying to cover the whole of the skeleton. Those are no longer acceptable anywhere really, and one needs to follow scientific societies' recommendations on how and when to image. And that's where it gets a bit more complicated, because many countries and many scientific societies have their own guidance. There are similarities, but there are also quite common differences. And if you depend, I've worked in different parts of the world, and things are dealt with a little bit differently, but it can make a difference. So one needs to really work with their local CAP team and follow one algorithm accordingly. And in Canada, the Canadian Pediatric Society has published a couple of practice points, and I refer you to their website. Everything is available, and one of them specifically looks at the assessment of fractures. And there's another practice point which is just fresh off the press in July this year, which looks at suspected traumatic head injury in this cohort of patients, and it's basically being practicing in this part of the world. We should really look into these practice points in detail. I mean, if you want specifics about the radiology side of things, of how to perform the skeletal survey and which views do you need, I think the British literature is very, very mature, to be honest, and they have revised editions, and everything's available online. And there is also a very good document specifically look at skeletal surveys from the ACR, which again has been revised relatively recently, which you can find quite easily online. There is one paper which I'd like you to highlight to you. This is fresh off the press, literally last week, which is coming from the cohort from the European Society of Pediatric Radiology, which looks a little bit at imaging in suspected child abuse and gives a very, very nice algorithm on their recommendations of who should be getting what and when. Obviously, based on the published literature. But I want to bring something else to your attention that led by the same group, mostly from the ESPR. There is currently a massive project going on, which is entitled the International Consensus Guidelines for Imaging in Suspected Child Physical Abuse, which includes 30 national and international scientific societies and now over 120 people. And outside Canada, I'm showing you the areas and places which are involved. And from Canada through the CAR, there's myself and Dr. Tahani Ahmed in Halifax, who's a pediatric neuroradiologist representing the CAN SPR and the CAR. And what's going on, basically, the group of researchers have been divided into 5 specific groups, and are looking intensely at all the published literature, trying to come up with consensus statements and consensus guidelines that will eventually be endorsed by all the other societies to try to break kind of that slight differences which we find depending on where we function. And obviously all being based on the literature which is accessible at the moment. So this is, at the moment, we're kind of at this stage. The consensus statements are currently being written. And so I expect that this group will be publishing over the next 12 months, and please look out for the literature accordingly. It's a great project led by Professor Ama Kafia from Sheffield in the UK. She's got a PhD student who's been rolling with this and working very hard on this project. So in conclusion, because I'm running out of time, it's a complex, difficult topic for 3 reasons, really. The stakes are high. It's a very emotional topic. And unfortunately, in some situations, opinions can differ where we've got some gaps in the literature. So one is trying to close those. From a personal perspective, if you could take away awareness of the condition and awareness of the imaging and what's out there and where to find the information, that would be great. From an institutional perspective, the most important thing is to work interprofessionally with your CAP team and standardize what you do. And as I said earlier, please be aware of the ongoing work at international level. If you want to take a screenshot, take this one. These are kind of overview papers, which I find quite helpful. And this is the recent paper which I mentioned just now, which is really worth a read, in my opinion. And finally, that's the feedback form, and that's my email if you would like to get in touch and ask any questions after the session as well. I'd be more than happy to reply as best I can.
Thank you so much, Dr. Sapras. That was an excellent talk. I learned so much. We will hold the questions till the end. And now I request Dr. Berger to share his screen and present on imaging of elderly abuse. Thank you.
Thank you, Adnan. I want to specifically thank you, as well as CETARS and the CAR, for inviting me to present on this topic. I'm at Sunnybrook at the University of Toronto, and I will be discussing the imaging and elder abuse. It's a bit difficult to follow the topic in the pediatric world because it's so much more robust, as I will touch upon in my lecture as well. I may be dating myself a bit as well by the next slide, which says that elder abuse can be thought of as not accidental injury in the elderly, but I just learned there's more modern terms for the pediatric world. So thanks for educating Sam as well. That was a great lecture. I have a couple disclosures. The most major one is that this presentation would not have been possible without the input from Hans Niebuhr, who is a good friend and emergency radiologist in Belgium. Here he is. And I would also be remiss not to acknowledge the colleagues downtown at the JDMI, which is somewhat separate from Sunnybrook, but still all great colleagues in the same university. But they have actually, as will be shown, greatly contributed to the awareness of this topic in the literature. So thanks to them. The images in this presentation come from Hans, except of one that is in the general literature, but none of them have been proven to be the result of elderly abuse, nor have they been proven not to be the result of elderly abuse. It's not as well established as the pediatric world, and I'll touch on that. And then we'd also like to recognize the lack of attention to prevention of elder abuse among the medical profession. So the teaching objectives are to get some awareness around elder abuse issues in emergency radiology, describe possible clinical and radiological signs of elder abuse, and identify the diagnostic imaging limitations and opportunities for detecting elder abuse. And I've included here and at the end as well is the QR code for evaluation, but that will be on the last slide too. So that's the start, raising the awareness of abuse in elderly. And when we look at the definition of elder abuse, it means the intentional act or failure to act by a caregiver or another person in a relationship with an expectation of trust that causes or creates a risk of harm to an older adult. And of course, that's a bit of a tricky statement, but within this topic, an older adult or an elderly is defined as someone age 60 or older. And of course, we know that is a very wide spectrum of patients. The abuse can be physical, verbal, psychological, sexual, financial, or as stated, a lack of action, so neglect. In a bit more detail in this diagram from the CMIJ journal, physical abuse, all these can range quite profoundly from, for example, physical abuse, slapping, to even severe beatings or pushing down the stairs, for example. And you can intimate from that the wide variety in the other factors as well. So again, we're mostly trying to raise awareness because there's a result of this to the patients that are involved. They have a worsened quality of life, a higher mortality, and a higher incidence of chronic conditions like depression and dementia, which will also predispose to some of these issues. So prevalence, as sort of estimated, is that this happens in 10% of older adults in the community, but it's quite a bit higher in institutional environments. And we acknowledge that there is a quite considerable underdetection and underreporting in these patients likely. From some estimations, it could be 2 to 18% in the emergency department, depending on which country and the reporting that they do. But again, to stress, it's likely an underestimation because oftentimes we're dealing with cognitively impaired patients. So what are risk factors? A familial culture of violence, social isolation. Again, dementia and depression can be either the result or a risk factor for the abuse. Dependence on a caregiver or shared and living arrangement, financial stress, or abusers with mental issues, drug abuse, and dependence on the victim. Again, under reporting, as far as sort of assumed, it's less than 1 in 24 cases is detected and reported. And there is a lack of disclosure by the victims. Again, reiterating, there's oftentimes a cognitive or sensory impairment. There's, of course, dependence on the caregiver and fear of isolation or the lack of continuation of the caregiving. There can be personal or familial shame involved and fear of reprisal. Some, especially elderly patients, are quite stoic and being perceived as ungrateful. So for the healthcare provider, we are often the victim's only contact outside that caregiving environment where oftentimes this abuse takes place. And while there is mandatory reporting in the US and Canada and possibly also other countries, we still are likely underreporting it, even despite that, due to these factors stated here, mostly lack of our awareness and training, a lack of screening, which has been much more established in the pediatric realm, and lack of knowledge, or even in other countries, maybe the reporting mandates. Also, it's very common and understandable that there is a fear of straining the patient-physician relationship. There's time limitations, as we all know, and uncertainty of the diagnosis is contributing as well. So it's good to highlight that there is actually now an World Elderly Abuse Awareness Day on June 15, which we can bring forth in future years, hopefully. So raising awareness, this topic was only first described in the 70s, which is a bit after the pediatric non-accidental injury, as well as the interpersonal violence that a colleague in Boston is very active in promotion of. But if you look at the PubMed data and you type in child abuse imaging, which is a wider net than child abuse radiology, and the same for elder abuse, you see that there is about over 3,000 results in the pediatric world and only 29 in the elderly world. Again, I have to give kudos to Professor Downtown, colleague Murphy, who provided the first dedicated radiological hit. And you'll see later that that's actually within our society here. But the authors identified a large gap in this reporting of elderly abuse. Most recent, and this has actually been superseded, there's now a few more recent publications, including the North American Clinics of America. But the radiographics article is something I wanted to highlight here. So this is a list of the most pertinent publications. And again, we're, as the image on the top right shows, trying to study this more, but within this list of publications, all the ones that I now highlight in green are from the same collaborators that have really pushed this topic forward again, with two of these, and the earliest one published in our journal, the Canadian Association of Radiologists Journal. Again, and here they are, very much giving kudos to Karjay and the Downtown colleagues for being at the cutting edge of this field. So, given the lack of what's known in literature, I think the raising of awareness so that we can all become more vigilant on this is important. Radiologists so far have had a limited contribution due to lack of training, lack of knowledge, and again, very different from the pediatric world that was far ahead of the elderly world. With gaps in inter-team clinical communication also existing between our referring colleagues and radiologists, the presence of information is very important in the detection of these things. Of course, the radiologist is often not in the room with the patient if they're reporting radiographs or CTs, but the physical abuse component can be seen, for example, by our technologist, or if it's stated in the clinical history, which is important. So abrasions, bruises, and lacerations, fractures, if patients come in with use of restraints, there's burns or unexplained pain, again, depression as well, and importantly, a delirium with or without worsening of dementia and related new behavioral problems may indicate that there's ongoing abuse. This clinical input is extremely important, and as in all of radiology, our results get better with proper provided history. This is certainly true for detection of elderly abuse. So when we look at some clinical signs and trauma mechanisms, what often occurs is beating the victim with fist or striking the patient with objects that people find in the vicinity. So this leads to fairly typical distribution of injuries. The upper extremities from trying to protect against the impact, as well as maxillofacial, dental, and neck injuries, and injuries to the skull and brain. So these are the highest risk regions of the body. Lower extremities and the torso are involved, especially if falls have been incurred, falls downstairs or either from standing. And open wounds often occur within the published literature. Internal injuries also occur, and of note, these can often be pelvic related, bladder and urethral injuries as well. So again, important if you see the patient yourself or to instruct your technologist to check for bruises on the chest and internal injuries, as well as upper extremity injuries, including dislocations. As radiologists, we are actually in a very unique position to try and detect these injury patterns in child abuse, and we should probably try to detect the same fashion in elderly abuse, although it is more challenging because we are faced with more age-related changes and comorbidities like osteoporosis, which may give a more natural explanation when a low mechanism of injury is provided. And drugs can also affect some of the bruises and hematomas that we are seeing. However, there's a striking similarity of clues when compared to children. So the combinations of visible injuries and findings on imaging and the discrepancy that may happen with the history provided, especially the low mechanism injury and some of the findings that could be more akin to high mechanism injuries. Multiple injuries at various stages of healing also occur in the elderly abuse. Malalignment after healing from not presenting with the initial fracture and not being casted, for example, and multiple hospital visits with injuries over time. Again, this is a bit more difficult in osteoporotic patients that can have multiple fragility fractures. Again, a combination of visible injuries and findings of imaging will oftentimes involve the upper extremities, for example, ulnar fractures with bruising of the forearm, maxillofacial fractures, and of note, the midface and zygomatic fractures happen more so on the left. Posterior rib fractures with posterior torso bruising. And then the fractures can mimic a more high energy pattern, so upper rib fractures and anterior sternoclavicular dislocation after posterior shoulder rotation by the impact of the caregiver. Some examples, again, these are not proven to be results of abuse nor proven not to be results of abuse. The upper extremity fractures, for example, the mechanism of trying to avoid an injury with an isolated ulnar fracture, and the bruising and swelling of the forearm, as you can see here in this case. This is also seen in intimate partner violence, similar mechanism. And I wanted to recognize Dr. Bharti Khurana from Brigham and Women's in Boston, who's doing the research in this regard. Maxillofacial fractures after a fall, as you can see here, periorbital hematoma and left facial fractures. Again, it's happening more on the left than the right. The same in this patient with, again, periorbital hematoma after a provided history of fall with the periorbital swelling and intraconal retrobulbar hemorrhage with nasal bone fractures as well. Posterior rib fractures in combination with posterior torso bruising. Here is an example, and again, this may mimic more higher energy trauma, especially in the osteoporotic patient. As you can see here, the line of the fractures that we normally would associate with higher energy. The anterior sternoclavicular dislocation after a posterior shoulder rotation. This is the case from the literature. As you can see, the bruising is quite extensive. A lot of these patients are on blood thinners, and this may be much harder to detect on the radiograph. Oftentimes, these are rotated and difficult to detect. The mismatch, again, to highlight reported low energy mechanism, but then sort of higher mechanism findings like the multiple rib fractures with the extrapleural hematoma and a hemothorax on this case. Multiple injuries at various stages of healing, similar to the pediatric imaging findings. As you can see here, the healing fractures and the more acute fractures after reported fall in a nursing home. Malalignment after a fracture, again, because of failure to report to the hospital and be immobilized. And multiple different visits to the hospital, as you can see here in 2016, proximal humerus fracture, in 2017, the ulnar fracture, and in 2017, but later in the year, rib fractures as well. So we recognize that there's a less clear pathway for pathognomonic injuries in the elderly, and it is challenging because the age-related changes, medical history often being poor, and the comorbidities, as well as the drugs, anticoagulants and corticosteroids. So from the referrer's perspective, in case of trauma of elderly, it is imperative to provide the radiologist with good information and an adequate recent history so that we can be better aware of this. And one of the key things is the reporting of a clinical frailty scale. And I wanted to show it here. I see the lines are misaligned, but basically this is from the CMAJ journal, where you can relate outdoor and indoor activities to a score, and the higher that score is, the more people are considered to be frail and fall into this spectrum. From the radiologist perspective, in the case of trauma, pay attention to the information, and the correlation of history with your imaging findings is probably the most important topic to be aware of. In general, in case of trauma in elderly, there needs to be very good communication between referrers and radiologists. We need to keep educating and discussing to detect this intentional trauma versus accidental trauma. The radiologist technologists are very important in recognizing some of these issues. They are in a unique position to see the patient. And we need a ton more research to get to the level of the pediatric world. Development of AI tools is also very important. So in conclusion, and sorry for running a bit over, but we need to be aware of this topic, be aware of the suggestive radiological findings for abuse of elderly, and we need to train and communicate everyone involved in care, including the technologist. And future studies are still very much needed. And I want to thank everyone here, including people from far overseas, I've noticed, as well as our French-speaking colleagues in Canada. And again, Hans Nieboer from Belgium, as well as the colleagues downtown, for advancing the knowledge. Thanks.
Thank you, Dr. Berger, for that wonderful presentation. I think Sam is also here. Are there any questions, please? Please type your, you can type in your questions into the chat box, and the speakers will be happy to answer any questions you have. Okay, I have a question to both of you. Actually, two questions, but I'll start with the first one. When you look at a radiograph or a CT scan, and you suspect that there is this possibility of abuse, how do you communicate that finding? Because it's such a complex issue. Like, you don't want to go wrong here. So how do you communicate that with your referring physician, and what kind of do you have any system in place in your institutions?
I'll go first. I mean, normally what I would do is I'll first roll through the clinical notes, which are available. We're lucky to have Epic, so I can kind of work through whether this was already raised and questioned. If not, then the first, and if I'm very suspicious, I would basically either pick up the phone or send a message on the system. We can communicate internally through our digital system, and identify that, has this been considered and is this being looked at or not, and make sure that the communication gets closed. The catch is when it's an external physician, if it's a primary family physician, then basically one needs to pick up the phone and say, there's a suspicion here, you may want to send the child in, or sometimes even pick up the phone and speak to our community, our CAP team, before even reaching out to the physician themselves.
Thank you.
Yeah, thanks. My suggestion will be along the same lines, and is sort of extrapolated from what was instilled in me while doing the residency training, when there was a lot of focus on the pediatric pickup of this. But it is a loaded topic potentially. So verbal communication with the referring team, I think, is important. And if that is not possible, and if you still have some doubt, then especially in the elder world, that it's not as easy to make the diagnosis, also with lack of literature, but you can at least mention a potential discrepancy between the findings in imaging and the provided history, without mentioning a topic of abuse at verbatim, but sort of at least highlighting the potential discrepancy between the findings and the provided history.
Thank you. Sam, in the pediatric world, is there a process which is already outlined where you have social services, everyone gets activated when something happens, when you suspect something like this, suspect abuse? Is there a process, at least in your hospital? Is there something?
Yeah, I think this is at an institutional level, really. And kind of, I'm not sure, to be honest with you, I'm relatively new to Canada. I've been here for 2 years. I don't know from province whether there's provincial differences. I suspect there are, because the provinces do function very differently healthcare wise, but it's mostly done at an institutional level. And realistically, what one needs to get comfortable with is their local arrangements. Now, as I said earlier, the catch-22 here is that when you look at the literature, and I mean, if you've worked in different settings, things get done quite differently in different parts of the world. So the attempt at the moment is to try at least to agree what imaging needs to be done in these scenarios. How you get there, that's probably very, how can I put it, very fluid, and very much depends on how each institution functions. But what we should be doing, the literature should be saying the same thing.
Okay, thank you. Are there any other questions from any of the participants? Please type in your questions to the chat box, please. I have one more question to both of you. Neglect and abuse, there's a very thin line there sometimes. How do you differentiate the two, like neglect and abuse?
I'm happy to go first again. Well, I mean, I think it's either of them are wrong. And if we detect, so I'm not really sure I can differentiate between them. Realistically, if you think about neglect, which leads to an accident, that's very hard for me to prove, because all I see is the accidental injury, right? Abuse tends to present radiologically with a slightly different, if it is one of those kind of highly associated type of injuries, then that would be abuse. But whether through neglect somebody actually has an accident, that we cannot really tell from a radiological perspective, I think.
No, and in addition to that, I think neglect is more something in retrospect, oftentimes. So if the patient comes in at a later stage, and in both the pediatric and adult realm, you can see like ongoing healing, for example, or in the elderly malunited fractures. So that has been neglected in the past. So oftentimes that is either comes to our attention either in the hospital later down the line, or people can be found by other people than the immediate caregiver in a delayed fashion. So the neglect will still come to light as a form of abuse, which it is, in those fashions, I would say.
Okay. Are there any questions from the participants? I don't see anything in the chat here. I don't know, Furko or Sam, do you see something there in the thing? Okay.
I don't. If I have a question, actually, if I may, if there's no from the participants. Dr. Berger, in your presentation, both presentations were excellent. Thank you very much. Very informative. You presented data from the literature in terms of publications in the pediatric population compared to the elderly population. There was one year, and I couldn't tell on your graph, but there was one year where we did see a fairly significant number of publications in the elderly abuse literature. And I was just wondering what the source, if you could postulate as to what the source of that peak was. And I'm wondering if it had anything to do with perhaps a funding situation, and if there was a way of, replicating that situation so that we could see more research in the area and see more literature in this important field. Thank you.
Yeah, thank you very much for that question, and a great pickup. It's, I think, very hard to know why that peak existed. It may have been a result of the group downtown who started to publish on this. There is a big skill differential between here. I can briefly share my screen, maybe. Let's see if that works so that I can show the actual. I think you're mentioning this was the. Can you see the? Oh no, sorry.
Yes. Thank you.
So yeah, this is the peak. Unfortunately I took this from PubMed, so I cannot see which year it is. But given so this is in the 70s, and to the right is current. So I think this aligns with the 2013, but I would have to verify. I wouldn't know. But what I want to draw the attention to, this is a total of 29 results. So these are one publication, or maybe two, right? Whereas these bars are like hundreds of publications every year. So the scale of these are not, so it may seem like a tremendous peak,
but it's not so much.
But it's only a few publications, if that makes sense.
Yeah, thank you. Oh, we're getting some questions.
Yeah, we have a question from Dr. Keeler. She says, great talk. In elderly patients with dementia, the risk of injury and osteoporotic fractures are common. History provided is poor, other than, say, ulnar fracture. I suppose that's what you meant. Are there any other areas to focus on?
Areas like areas in the body, yeah. So the upper torso injuries, and what was interesting to read is that the pelvic region, so the bladder injury and the ureteric or urethra injuries, yeah, there's all sorts of questions behind those, I think, but those were the other regions that came up in the literature. But again, acknowledging that the literature is really sparse at the moment, and again, this may mimic in part the intimate partner violence type of imaging results, although that's in a bit younger cohort and needs more, usually is more violent, but there are some mimics, and we just need to study this a whole lot more.
Okay. Any other questions? There's one more question here. what do you mention in your written reports?
Really it depends on the scenario, but for the cases where the question is on accidental injury, then we have got templates, and we kind of have agreed templates between us. What I want to stress about is that when we think that there is a possibility of this being an accidental injury, we double report the case, and I think that is quite common practice across the world, to be honest. And we ask our colleagues to second read, and then we double report it formally. So there are two names actually mentioned on the report. It gives increased confidence both to ourselves and to the receiving physician that that the findings are much more definitive than if it was one person. I mean, it also increases the sensitivity, because sometimes we're looking at subtle things. So not only increases confidence, but increases, 4 eyes are better than 2. But we have templates. So I would mention that this may be non-accidental injury or not, if I think they are typical, or if I think that these are old versus new. It depends. It very much depends. But I mean, I think from a radiology perspective, what we can do is try to leave the least doubt that we can. And if we're in doubt, we very regularly say we recommend repeating imaging between 11 and 14 days, which is very commonly done, because that again both increases sensitivity and specificity in what we report. So we're not sure, we just say we're not sure about this finding, we suggest repeat. And that's the way forwards.
Are there any other questions? Yeah, go ahead.
Sorry, I'll answer that for
Go ahead.
elderly abuse. So again, repetitive, sorry for that, but the documentation and guidelines just don't exist in the elderly world. But what I do is, first of all, I really try to get a hold of the physician and the referring team, and then you can document who you spoke to, what time, and state that you discuss a potential discrepancy between the imaging findings with the history. I personally don't use the word abuse or non-accidental injury. I purposefully keep it not vague, but stating that discrepancy. And again, it's mostly in patients that either have multiple injuries over time or those typical injuries that we discussed.
Thank you to both Sam and Foucault for excellent presentations. I think we are right on time, so we will conclude the webinar here. Julie and Courtney, thank you so much, and to the entire CR team for your hard work. I think without your support, we couldn't have had this webinar. I would also like to, and please take a minute to complete the speaker evaluation forms, which has already been posted by Courtney and Julie in the chat box. The next webinar will be early 2024. Just watch out for the promotional material closer to that time. And again, I'd like to thank Bayer for supporting this event through an unrestricted educational grant. And for all the participants, thank you so much. I know it's a busy time of the day, so I thank you for taking your time to participate in this webinar. And we will be emailing your certificate of attendance pretty shortly. And enjoy the rest of the day. Thank you so much, everyone. Thank you, much appreciated.